Okay, let's spend some time talking about why image analysis is so important for medical radiography. So, the purpose of image analysis is so that we can understand how to evaluate projections for acceptability, determine how to improve positioning and technical skills before repeating a projection, and continually improve skills. So, this is a lifetime learning skill that's going to help reduce patient dose as well as consistently give us a way to consistently improve our X-ray images. So, looking at these two images, it only takes 2 to 3 degrees of rotation to affect the appearance of the lungs and cause differences in brightness values along the lateral borders of the chest projection. So if we look at the image on the left, we can see a sternoclavicular end free of superimposition with the thoracic spine. That means that given the marker on this image here, so this is the patient's right side over here, ask yourself this question real quick. Which side is this patient rotated towards? So we know they're rotated because we can see that the sternoclavicular end of the left sternoclavicular end is not superimposed with the thoracic spine. So we know, for example, in this case, the patient's right side is closer to the image receptor. So in order to correct this image and make it look like the image on the right, we need to make sure that the patient is the plane of the patient's thorax is parallel with the plane of the image receptor. That means we need to move the left side towards the image receptor. Another reason why we should consider image analysis closely deals with the wrist bones. So, for example, in this case, we can see the trapezium very clearly on this image on our far left, free of superimposition. It is not being demonstrated on these other images because we have not appropriately depressed the metacarpal so that it was aligned with the plane of the image receptor. In that case, this first metacarpal bone is now occluding the trapezium. It is important to use proper terminology when we're discussing radiographs, both with the technologist and especially with any physicians that we might be discussing them with. So we want to appropriately describe all the terms related to the path of the X-ray beam, patient's position. So that would be things like whether they're in the oblique position or upright or recumbent. A lot of the terms that we sometimes use, I want to differentiate between position of the patient and projection. When we talk about an AP or PA projection, we're talking about the path of the X-ray beam, not the actual positioning of the patient. So again, a lateral projection means the path of the X-ray beam is incident on the patient's lateral side. And then we also want to be able to clearly articulate the ways that the structures can change in position as the patient moves in a predetermined direction. So this would be things like caudal, distal, more directional kind of terms like proximal, things like that. So familiarity with all this terminology is going to help you understand statements that are made, for example, in reports, as well as converse competently with your coworkers. So I would strongly encourage you, if you're not familiar with all this terminology, to go ahead and start making flashcards. If during the course of this lecture I mention a term that you're not familiar with, review that, add a flashcard, and it's your responsibility to start documenting your familiarity with this terminology. I apologize, it looks like this slide was formatted inappropriately by the computer when it was imported into this program, but I think we can still see what we need to see. This is discussing, again, kind of repeat, but characteristics of an optimal image. So an optimal image is going to demonstrate all these things: demographic information, correct markers in the correct place and that are not superimposing volume of interest, desired anatomic structures in accurate alignment with each other, maximum geometric integrity, appropriate radiation protection, the best possible contrast resolution with minimal noise, as well as appropriate spatial resolution and no preventable artifacts. Now, there are a number of things that have changed with the advent of computed radiography and digital radiography and image and evaluation. In the past, we would orientate image receptors at like an angle to longer pieces of anatomy. But for the most part now we want to align our anatomy with the long axis of the image receptor, and that's true for both CR and DR. Now on these images, I don't know if you can see this real clearly, I'll kind of blow this up a little bit so we can look. The image on the left looks a little bit different from the image on the right because post-processing they've applied contrast masks. You can see them right here and right here to cover the anatomy that was exposed. Now we want to be very careful with applying that kind of post-processing, so let's talk a little bit about that. Post-processing manipulation, the reason we do this is to enhance contrast, and it will add a black background over the areas outside of the volume of interest. So we should only mask exposed areas if it's matching the collimation border, even though it's possible to mask areas into the exposed area. And be very, very aware that if a projection has been masked and it's sent to PACS that way, it cannot be unmasked. So depending on the facility, it may be appropriate to send both the unmasked and the masked image so that the physician knows that, hey, there was additional anatomy shown on this projection, but I've sent a masked image just in case the contrast was affected by the way that the image was. Of course, the way to prevent this period is to collimate appropriately. So it is helpful to have a form or a formula for how to evaluate these images. I know I'm throwing a lot of information at you right now, and we're going to rely quite heavily on Merrill's to make sure that we're doing things. But having a form or some kind of systematic approach is going to be important because it will prevent us from missing important details as well as provide a structured pattern so that we can use this even if it's a stressful situation. And I'm going to talk about the form right now, and then later on we'll discuss a mnemonic that may be helpful. So here's the form. It's huge, right? And this is why it might be more helpful to have a mnemonic. We've got a whole lot of information here. Is the projection accurately displayed in terms of marker, demographic information, annotations, are they appropriate? Is the collimation appropriate? Was the focal spot used? Was an SID appropriate? Were the gonads shielded? There's a whole lot of things to think about when we're looking at these images. So, demographic requirements. We need to be making sure, especially in this digital age, we need to be making sure that we have correct patient name, age, date of birth, patient ID number, facility name, examination time and date should all be displayed in everything that we're doing, period. When we're marking projections, a good rule of thumb is if you are shooting an AP projection, you'll have your marker face up. If you're shooting a PA projection, you can have your marker face down. If we're doing AP or PA projections of the torso, vertebra, or cranium, place the right or left marker lateral to the side being marked. Okay? For lateral projections of the torso, vertebra, cranium, etc., place the marker on the image receptor will indicate the side of the patient's position closer to the IR. Right, so for example, for a left lateral chest x-ray, we want to make sure that that left lateral marker will be projected on the left side in relationship to the patient. For AP and PA lateral decubitus projections of the torso, vertebra, and cranium, the marker placed on the image receptor identifies the side of the patient closer to the image receptor and is placed on the correct side of the patient. So any kind of decubitus position, we will mark the side up. And then it's also helpful to indicate that the side is up with like an up arrow. Now, for a projection like this one illustrated here, where clearly we would not be able to appropriately collimate and also include a marker on this image, we need to still have like maybe the corner of our marker in the image if possible, and then we can come in post-processing and annotate a marker into the image. But anytime adding annotations or marker, make sure that we aren't covering up the original marker. We want to keep the original marker clear that this is a right marker on the image that we've only seen partially, but I've added a right digital marker somewhere else. So anatomic structure requirements and placement as a general guideline, we want to position the volume of interest on the image receptor, and the long axis of the part is going to be aligned with the long axis of the image receptor. And it's going to be oriented for the best display and the tightest collimation. That's kind of critical. we want to tight collimation on everything as much as possible. So with digital radiography, the volume of interest can be placed anywhere on the image receptor without reducing spatial resolution, which is interesting. But when we're talking about long bones like projections of the humerus and lower leg, that may need to be placed diagonally on the image receptor. This is not advisable when we're using computed radiography. It will result in a poor exposure field recognition and probably some histogram analysis error. What I'm talking about is this. We used to do this on film quite a bit, where we would place the long axis of a bone diagonal to the plane of the image receptor. But this kind of thing will create a histogram analysis in this area that the machine won't know how to recognize it. So don't do this. As a general rule, you'll probably see people doing this in the clinical sites because they do not understand how histogram analysis works. They're probably techs who did the boards prior to the rollout of all this DR, CR kind of considerations, and they're not aware of the impacts of this on the post-processing for the computer. Collimation is a general guideline. We need to demonstrate a small collimated border around the entire volume of interest. As a rule of thumb, an inch or less of a border for collimation. The only time that this does not apply is when the entire image receptor must be used to prevent clipping of any needed anatomy. One thing that comes to mind immediately is a KUB, so chest, abdomen projections. It's helpful to use this collimator guide that's actually on all the machines that are out there. It'll tell you how collimating is working on that machine, and learn to be very confident on the collimated field even when it looks smaller than an area that you know the size of the image receptor is. That has to do with magnification, and so be confident with the fact that even though it looks smaller, this is collimated appropriately for the image receptor that you're using, and always avoid having a light field that's larger than your image receptor, of course. Now here's another no-no that again comes over from the world of film that simply just doesn't work with digital systems. We used to rotate the collimator head. Rotating the collimator head doesn't affect the alignment of the beam with the grid, which is interesting. The beam is not going to cause like a grid artifact or something like that, but it should be avoided when we're using computed radiography and DR, because it can again affect the exposure field and the histogram analysis process. We might get some kind of histogram analysis error here. So we want to really avoid over-collimation at the same time, and I think sometimes that as y'all interact with technologists in the clinical site and they are, coning it back out on you or something like that, that may be because they've seen anatomy clipped in the past. So one thing that can be very helpful in terms of understanding beam divergence and how not to clip anatomy is anything that projects a shadow onto the image receptor will be included on the image. So for example, understanding divergence and magnification processes, this thumb is very close to the border of the light field right here, even though the thumb is way over here. Do you understand what I'm saying? So this shadow is actually the area that's going to be included on the image receptor. And what's interesting about this image is if you look, this is the most distal, second most distal, third most distal, fourth most distal, and then this is actually touching the image receptor. So we can see the effects of magnification in that this shadow is much further from this than here, and we're seeing a diminishing returns until the shadow is directly on top of it. Thinking about anatomic relationships, and this is where we're going to really need Merrill's, and we're going to rely a lot on our atlas to think about whether positioning routines are appropriate and in making any accommodations the patient may need. So we need to be able to actively correlate anatomic relationships and positioning procedures. This is especially important if we're doing any kind of orthopedic work or working in the operating room. Identifying anatomic structures, because especially if you're working in the OR, the doctor may say, hey, just show me the mortise joint. And so knowing that they want an oblique position of the ankle, you can go from there. Now, off-centering, of course, is going to close up a joint, so we want to be very careful that we're centered to the joint or any anatomy of interest. So if we're doing a knee, we want to be centered on the knee, because if we're not centered on the knee, the joint will be closed. Understanding things like magnification, elongation, foreshortening, and how that might impact an image is going to be really, really helpful. So we'll be looking at examples of that in just a moment. And then being able to distinguish between structures of similar shape and size, especially things with like wrist bones and stuff like that, or when we're looking at the shoulder. Being able to determine the degree of patient obliquity, degree of extremity flexion, and joint spaces. This is a skill that we are going to test and acquire throughout this entire trimester. Understanding what amount of rotation may be on an image requires a laundry list of check marks that we are going to critically evaluate, and we are going to be looking at that projection by projection. All right, this is totally impertinent to the presentation here, but if you have questions, I guess send me something on email.